Well, welcome everybody, and thank you for joining us today for the American Cancer Society Cancer Action Network's 2023 Colorado Policy Forum. I'm R.J. Hours. I'm State Government Relations Director for ACS CAN here in Colorado. We're the nonpartisan advocacy affiliate of the American Cancer Society, and we work to pass evidence-based laws and policies to help us eliminate cancer and make fighting cancer a national priority. Our theme this year, Celebrating Champions, Celebrating Progress, Celebrating Hope, is indeed in recognition of the fact that this is our 15th annual gathering, providing the opportunity to celebrate some successes, celebrate our volunteer advocates, our supporters, and celebrate the hope for the future that begins with the research and medical practice going on right here on the campus. And at cancer centers around our state, nation, and the world for that matter, because we are really such a global community now with research and care. So oftentimes with advocacy-driven and science and evidence-based policy at the Capitol, downtown, and in the nation's capital, we're able to help enable a lot of the work, the proceeds of the work, the results of the work that happens here. And sometimes that takes legislation. Certainly research takes funding, federal appropriations. And so ACS CAN's volunteers work really hard year-round on those efforts in reaching out to our elected officials on all of our behalves to make sure the funding is sustained and that the work continues. Opportunities here in Colorado include trying to pass a comprehensive biomarker testing insurance coverage measure for cancer patients, such as that was introduced last year by our terrific sponsors, Representatives Daphne Michelson-Janae and Anthony Hartsook, and Senators Janice Rich and Kyle Mullica. Though that bill stalled in the House this year, we will be coming back in 2024, and we're already taking some great steps to make sure that things are followed through and we get that bill passed in due course. So ACS CAN's fighting to achieve health equity, the just and fair opportunity for everyone to prevent, find, treat, and survive cancer, regardless of how much money they make, the color of their skin, their sexual orientation, their gender identity, their disability status, or where they live. And you can learn more about our advocacy work at the federal, state, and local level on all of these things by going to fightcancer.org. I want to make a couple of quick introductions. Our Vice President of Regional Advocacy, Mark Anderson, I saw come in the room earlier. Mark, if you want to stand. And then we've also got Kelly Moran, who here in Colorado and also in Utah is our Senior Executive Director of both states. Kelly, thanks for being here and all the support you give us throughout the year. My boss, Brooke Carlisle, our Managing Director here in the Rocky Mountain States, is also here. And Marissa Beasley, who's our Strategic Director of Alliance Development, is also joining us today. So with that, I'm going to transition to Dr. Schulich, our host. Gives me great pleasure to hand over this portion of the program to him. Just want to welcome him. Of course, he is the director here at the University of Colorado Cancer Center, among all of the things that he does and that we're grateful for. So thank you, Dr. Schulich. With that, I'll turn it over. Thanks.
So thank you, RJ. And a special thanks to all of you for coming tonight and everyone online and the panel participants and moderators. Thank you. So I bet most of you know these few statistics I'm about to talk about, and I think there's some more detail in some of the slides that are coming, but let's make sure we're on the same page here. So in the US this year, 2 million more Americans will be given the diagnosis of cancer, 2 million, right? And 610,000 Americans this year will die from cancer, right? And at the current rate, if we just had what we had today, do you know what your lifetime risk of developing a cancer is? Yours, mine, everyone's, anyone? Yeah, it's actually about 40%, so closer to 1 in 2, 1 in 2 in this room. And what's your chance of dying from cancer given the current statistics and conditions? Anyone? I know the team on that table knows, so don't answer. Yeah, it's about 25%, 20 to 20. So 1 out of 4 of us in this room will die from cancer, including me, right? So it's a big one, right? In Colorado this year, there'll be 29,000 new cases of cancer and 8,700 deaths in Colorado. And unlike most states, cancer is the #1 killer here. In most states, it's heart disease, but in Colorado, cancer is the #1 killer. So, I started off with doom and gloom here, but there's a lot of great news, right? So US cancer age-adjusted death rates have decreased by 33% since 1991. And in the 90s is when cancer death rates peaked, and they've been coming down. So a third better in the last several decades. We're in the midst of a moonshot program, which I'm sure everyone in this room has heard about, that President Biden has talked about, and we hear a lot about from the NCI, the ACS. And the plan there is to decrease the mortality of cancer by 50%. So wherever we are now, take it in half over the next 25 years. And we're well on our way, actually. But to do this work, we need you. And I know I'm speaking to the choir right now. We need your help in terms of support, advocacy, and participation, right? And my team has heard me say this a lot, but there are 4 main strategies, right? Prevent it. Why deal with cancer? Just prevent it as much as possible. If you can't prevent it, early detection. Catch it early, you can cure it. If you can't prevent it or catch it early, you better have good therapies. And that's what we spend a lot of time working on this campus. And importantly, you can do all 3 of those things, but you have to have multidisciplinary, holistic, equitable, global care of patients and survivors. And we have to take care of all citizens of Colorado equally, and all citizens of the United States and the world equally. So we here at the University of Colorado Cancer Center are very proud of many things, right? We're the only NCI designated cancer center in the state. And as a matter of fact, if you have a circle that's 900 miles in diameter, encompassing Colorado and multiple other states, we're the only NCI designated cancer center, right? So we fill a huge void. We have approximately 270 what we call cancer center members. And these are people doing all kinds of investigations and clinical care in cancer, 270 on this campus and other campuses, and a ton of tireless, dedicated administrative staff. You can see them in the back and on the side. And we're all laser focused on making new scientific discoveries, bringing them to clinical trials for our patients, and changing the standard of care in the US and around the world. We're very focused on taking care of our cancer patients. I spent most of today in the operating room taking care of somebody with a cancer in their liver, right? And I view that as one of the most important things that I do, in addition to doing things on a bigger and more global scale. So we'll provide new ways of preventing and curing cancer. We'll make new discoveries, and we'll educate the next generation. And with that, I will transition. It gives me great pleasure to begin the speakers portion of tonight by having some introductory remarks by United States Senator Michael Bennet. You know, obviously he's not in the room here, but he will be doing this via a video presentation. He's the senior senator from Colorado and has held office since 2009. His biography was at the table as you walked in, and I'm sure there are a couple of copies floating around, or if you want to go out and get one later, that's fine. We're very fortunate to have him record this video and send it to us. ACS CAN and I are deeply appreciative to the senator and his staff for providing this presentation. And now the video. U.S. Senator Michael Bennet.
So we're going to move ahead real quick and we'll show the senator's video shortly, but I wanted to move up our, we want to make a really special presentation this year as part of our celebration of progress and celebrating our champions in elected office. And I know JC Garcia is here from the senator's office, and JC, if you'd like to come up. Dr. Schulich, would you like to join us? So JC, I'd like to present this plaque in recognition of the appreciation of Senator Bennet and his work in the fight against cancer, and for co-sponsoring S2085, which is the Medicare Multi-Cancer Early Detection Screening Coverage Act that's now before the U.S. Senate. There's also a companion bill in the House, HR 2407, and we are just so appreciative of his support and sponsorship of this. This is about the third go-around, I think, on this bill. And so he's hanging in there on it, and we're hanging in there with him. But we sure want you to express our deep appreciation to him and everybody that's working on this bill.
Hi, everybody. It's Michael Bennet. I want to thank the American Cancer Society for inviting me to share a few words at this year's Cancer Action Network Policy Forum. I know from personal experience that early detection can make all the difference and save lives. In 2019, I was diagnosed with prostate cancer, and thanks to my doctors and the fact that unlike many Americans, I was actually covered, I was lucky enough to catch my cancer and treat it easily. This is not the case for many Americans. Access to life-saving cancer screenings is out of touch for millions in this country, particularly seniors, who account for 3/5 of all diagnosed cancer cases in the United States. Fortunately, there are solutions that can help close the gap and reduce transparencies in cancer treatment. And one of them is my bill with Senator Crapo, the Medicare Multi-Cancer Early Detection Screening Coverage Act. This bipartisan bill would require Medicare to cover a cancer screening test, which will help lower costs and save lives. I'm deeply grateful for the American Cancer Society Action Network support and for the over 500 leading healthcare organizations that have endorsed this bill. Together, we can end cancer as we know it. Please keep up the push to pass this bill in Congress. Thank you for your advocacy and for being here today.
Well, and again, our thanks to Senator Bennet for all his work on this great legislation, and really a number of the things that he's done while he's been in office to help in healthcare in getting speedier development and approval for medical devices and procedures and prescription drugs and treatments. It's just been incredible to work with him over the years. Again, thank you to JC Garcia. You're a constituent advocate, I believe, in the senator's office. So if you have Social Security check problems, Medicare problems, JC's your person. So, so we're going to move to our second half of the program today, and I'm really pleased to turn things over to a good friend of mine and ACS CAN's Dr. Valerie Curtis. She is our first congressional district volunteer advocate, and I'll let her say a few more words about herself and then introduce our panel and have that part of the program. I also wanted to point out, before I forget today, we are celebrating some of our past accomplishments. I've got about 4 boards up here with some of the state legislation we've passed since about 2001 in access to care and in tobacco control. And I think I got most everything, but I'll keep working on it and add stuff. We've also got a placard there about biomarker testing, which I don't have to tell anybody in this room, I think, how important getting insurance coverage is for that. And we've also got a marquee with the front page of S2085, suitable for picture taking after the program with the placard. And then just an example of one of the things I was really lucky to be a part of during my tenure with ACS and ACS CAN, and that's the page 1 of the Clean Indoor Air Act from 2006, which just celebrated its 17th anniversary last month. So with that, I'll turn it over to Valerie. Thank you.
Thank you, RJ. Hi, everyone. I said my name is Valerie Curtis, and I'm ACS CAN's first congressional district lead volunteer advocate. So that includes the city and county of Denver. I've also served as the state lead volunteer advocate. And like everyone who volunteers with ACS CAN, I have a strong belief that advocacy is critical to fighting back against cancer. I received my PhD in molecular cancer biology in 2011 and moved to Colorado the following year. I started a postdoctoral fellowship here at Anschutz and started volunteering with ACS CAN, wanting to make connections between researchers like myself and cancer survivors and advocates and legislators. So the American Cancer Society recognized very quickly that one of the consequences of the COVID-19 crisis was fewer people were getting screened for cancer, which can lead to delays in diagnosis, treatment, and ultimately a higher likelihood of disease progression and even death. Indeed, the findings of an ACS-led study published in the Journal of Oncology in February of this year indicated that millions of people in the United States continue to miss critical cancer screening tests during the second year of the COVID pandemic. The number of women who reported having cervical cancer screening dropped by 4.4 million in 2021 versus 2019 levels. The study also showed 1.1 million fewer women received breast cancer screening, and close to 700,000 men reported foregoing a prostate cancer screening test. Fortunately, ACS launched the Return to Screening Initiative in 2021 that has worked to support the development and regional and local materials for healthcare systems to utilize in improving cancer screening rates and state-based interventions to improve health equity in under-resourced communities. Pandemic-related disruptions have already exacerbated existing disparities in cancer screening and are likely to impact survival across groups of people who have systemically experienced social or economic obstacles to screening and care. And ACS CAN continues its advocacy efforts to ensure that access to and coverage for screenings are available and equitable. Consequently, that leads us to our featured program for today. It's my pleasure to kick things off by introducing our 3 presenters for this portion of the program. I know I'm looking forward to the insights they can provide. So presenters, please come up to the front table as you are introduced. And our speakers' bios are also included in the handouts that were available as you checked into the event earlier. So let's give a warm welcome to Dr. Marie Wood. She's the Director for Breast Medical Oncology and Director of Cancer Clinical Trials here at the University of Colorado Cancer Center. Dr. Christopher Lieu. who serves as co-director of GI Medical Oncology at the University of Colorado Cancer Center, and Dr. Sachin Wani, a professor of medicine gastroenterology at the University of Colorado Anschutz Medical Campus. So welcome to you all, and Dr. Wood, would you like to lead off the group?
Thank you. Do I advance my own slides? Yes. Oh, look at that. Previous. I wanted to sort of set the stage and provide some overview statistics of what we're all going to talk about. Myself, breast cancer, Dr. Lieu will talk about colon cancer, and our third speaker will talk about esophageal cancer. So as Dr. Schulich told us a little bit, but I'm going to break it down for you a little bit more. When you look at leading causes of cancer in the US in 2023, you can see here for women, the leading case of cancer is breast cancer, and colon and rectal will be number 3. When we look at what's killing women, unfortunately, breast cancer, despite all that we know and do to screen and prevent, is really still the second leading cause of cancer deaths. And colon cancer also, with some great screening tools that actually prevent cancer, is the third leading cause of death. For men, colon is the third leading diagnosis world, US-wide, and it is also the third leading cause of cancer deaths. When we look at esophageal cancer, which also has great early detection and screening and prevention strategies, it is not too far behind. So how do we do in Colorado? Dr. Schulich gave us some statistics, but sometimes I like to look at things by pictures. And if you look, as he said, the top cancer diagnosis in all individuals is breast cancer. Interestingly, when you look at Hispanic individuals and rural individuals living in rural areas, we are above the national average with respect to Hispanic women diagnosed with breast cancer. And we're about the average with respect to rural individuals. Looking at colon and rectal, interestingly, among Hispanic individuals, we are above the national averages for these populations. When we look at cancer deaths, again, looking at breast cancer, Hispanic individuals have a higher death rate when they are diagnosed with cancer. And individuals in rural areas seem to fare close to the national population. And again, when we look at colon cancer, we see among Hispanic individuals higher than the US average in terms of death rates. So these are things that we can really do better with. And a big shout out in the back, trying to hide, to Jamie Stutz, who provided me with a lot of websites where I could get this information, because it's just not easy to find. So one of the things we're here to talk about today is what is the impact of COVID on screening and diagnosis. The data that we just heard about was published in 2022. And you see here, when looking at national screening data between 2017 and 2021, there is a dramatic fall in breast cancer screening from 2019 to 2021, about 28%. And the same is also true for colon cancer. These numbers don't look any different, but if I did my math right, it's a similar percentage decrease. When we try and parse it out a little bit, thinking about breast cancer first, we see that the biggest decline was in the first year of the pandemic. So 2019 to 2020, fewer people missing their screenings in 2020 and 2021. So these are national numbers. The similar statistics for colon cancer, big drop in screening in 2019 and 2020 when everything was shut down, but a less dramatic drop. Still not an increase, but as you might expect with people making up things, but a similar decrease. When we look at cancer rates over this time, you would, as you might expect, there was a decrease in the amount of cancer diagnoses in 2020 because people just weren't coming in to get diagnosed. But we still saw the same decrease in 2020 and very similar statistics for colon cancer. So turning a little bit to breast cancer, thinking about the incidence and screening and what we know about Colorado. I do have to say that these statistics are very hard to get because we are lagging behind in our tumor registries and in our cancer registries at catching up with pandemic and getting all of these numbers. So what I did find was that, got this off an NCI website, is that you could see in Colorado, there was a huge decrease in cancer cases diagnosed between 2019 and 2020, suggesting that people just weren't coming in. Thinking now about, does screening account for that drop in death rates? I just want to remind you that the ACS now recommends women have the opportunity to screen between ages 40 and 44, but then recommends that women age 45 to 54 be screened annually, and over 55 should transition to every 2-year screening. ACS also recommends that you continue screening as long as you have good health. So for people over 70 who have a life expectancy of 10 years or more, we still do screen. So I found some interesting statistics on the American Cancer Society Surveillance and Health Equity website that shows that overall, these are the trends, and thinking about ethnicity and trends in breast cancer screening, we see here that white women, as we might expect, have very high screening rates, but very interestingly, Black individuals are catching up. And I think that that's actually great because we know that Black women have higher risk cancers. When we look at what's happening after the pandemic, we see increased screening for Black women, not so much for white women, not so much for Hispanic women. And I told you about some of those Colorado statistics. And the bottom line is Asian women, who probably have even a lower breast cancer risk than Hispanic women. Well, how do we do in Colorado just compared to the rest of the states? They always say when you're giving a talk, give your punchline. Really poorly. We do really poorly. And I think that's the message I really want to tell you here today. So when we look at either the ACS recommendations or USPSTF recommendations, which are slightly different, Colorado rates of screening are 60%. Looking at ACS with a range of 56 to 76 in all states, but we're in the bottom 10% of the states. Same if you look at USPSTF recommendations. When you look among uninsured populations, these rates of screening are always lower, but in Colorado, we might be doing a little bit better for uninsured, but we're still doing pretty poorly. And I would think that these are numbers that we should really try and move. When we think about Hispanic individuals and rural individuals, this is something that I pulled off our own COE website. If you look at Hispanic women or all women, if you look at all women having a mammogram in the state of Colorado, it's 71%. If you look at Hispanic women, it's about 10% less. And if you look at women who are living in rural areas, it's also about 10% less. Just to preview Dr. Lieu and give him some things to talk about, you can see here that that's also true for colorectal cancer screening for Hispanic individuals and people living in rural areas. So we're seeing lower rates of screening for Hispanic individuals and those living in rural areas. And I would think we can and should do better. So how can we do better? ACS, I think, does a great job of outreach, and we in the Cancer Center can maybe partner better to help with that. Education of not only individuals, but primary care providers. And we're working on a grant to think about how to educate primary care providers and individuals. And then access to screening. There are mobile units that actually, I don't know that you can do a mobile colonoscopy, but I don't think I want one, but there's a lot of screening that you can do on a mobile unit. And I did want to just highlight one pilot study we have here that will look at this. And this is Dr. Borges's study to evaluate breast cancer awareness statewide. So she's doing focus groups to really look at what people know and what are the unmet needs. And she will use this information to overhaul community outreach materials, which can be made available in toolboxes on social media and other areas. So thank you very much for your attention.
Thank you, Dr. Wood. And I'd like to introduce Dr. Lieu.
Thank you so much. And that's a wonderful introduction, Dr. Wood, and appreciate you stealing a little of my colorectal cancer thunder in that presentation. I'm Chris Lieu. I co-direct GI Medical Oncology at the University of Colorado Cancer Center. And just like Dr. Wood's presentation, we're going to do a brief primer on colorectal cancer, talk about the current screening guidelines for colorectal cancer. I want to show you some of the trends in the United States and also how we're doing in the state of Colorado. Certainly for colorectal cancer, these are the statistics, and this mirrors a lot of what you saw in Dr. Wood's presentation. Over 150,000 new diagnoses of colorectal cancer in the United States just this year. What does that also mean? It means that more than 50,000 people will die from colorectal cancer in the United States in 2023. And we also know that 1 in 3 age-appropriate adults are not getting screening for colorectal cancer, a largely preventable cancer, are not getting screened. And then this is probably the most important statistic I can show you. There are 1.54 million survivors of colorectal cancer that are living in the United States right now. That is a phenomenal number. And obviously we want to see that increase. In terms of how Colorado contributes to these numbers, about 30,000 new diagnoses of colorectal cancer in our state this year. And this will also be matched by around 8,600 deaths in Colorado due to colorectal cancer. What are some of the risk factors? Overweight or obesity, physical inactivity, smoking and alcohol use are risk factors for really any cancer, but a diet high in red meats, processed meats, and cooking meats at very high temperatures, also a risk factor, which is a little bit different than some of the other cancers that we talk about risk factors for. One of the take-home messages here, family history represents only about 3 to 4% of all the new diagnoses of colorectal cancer, looking at genetic syndromes like familial adenomatous polyposis or Lynch syndrome. So you don't have to have a hereditary syndrome to be diagnosed with colorectal cancer. In fact, the majority of our cases in the United States and across the world are not related to these familial syndromes. So who should get screened and when? There are a tremendous amount of organizations, including the ACS, who I'm going to show you, that have suggested screening guidelines for colorectal cancer. And this is the ACS guidelines. And I really have to commend ACS for doing the following. They lowered the age just a couple of years ago from 50 to 45. I'm going to show you why. ACS led the way here. And I'm going to tell you why that's so important. But really was the first organization to make the screening recommendation drop from 50 to 45. They say basically you can do this with a stool-based test or a visual exam like a colonoscopy. That's what our specialists like Dr. Wani do. These options are certainly anybody under the age of 75 or ages 76 to 85. That's really kind of selective screening depending on how healthy that individual is, and generally screening not recommended for people over the age of 85. You heard about the USPSTF, the United States Preventative Services Task Force guidelines. They actually followed ACS's lead a couple of years ago and also dropped their screening recommendation down to the age of 45. So what's your first take-home point? Everybody should start screening at age 45 or 10 years before the youngest case in the immediate family. 76 to 85, a selective screening and colonoscopy is the gold standard because not only can it diagnose colorectal cancer, it can also prevent it by removing polyps. Your take-home point number 2, and really makes sense, but I can't drive this point home hard enough, and that is if you find cancer at an early stage, you can get 5-year survival rates of greater than 90%. If you find it at stage 3, where it's kind of that regional metastases or metastases in the lymph nodes, the 5-year survival rate is still very, very good at 75%. If you find cancer at stage 4, that's where our 5-year survival rates really plummet down to around 10 to 20%. And so we've got to find these cancers, we got to find them early, or better yet, prevent them. So what are these colorectal cancer trends look like in the United States? These are the kind of curves that we want to show everybody. And this is what the incidence of colorectal cancer and mortality from colorectal cancer in our older individuals looks like. And we always want to be able to show these curves that go from 1970 to 2020 and see them decrease. And you're seeing these remarkable decreases in both the incidence and mortality from colorectal cancer. But this is the other take-home message. And that is when we look at our younger individuals, 20 to 49, since the 1980s, and particularly over the last 2 decades, you're seeing this year-over-year increase in the incidence in our younger individuals, in males and females. And when you look at the mortality, you can see this decrease down to 1990, and then you're starting to see the increase. What does this mean? It means that 49 new young adults are going to be diagnosed with colorectal cancer every single day in our country. And colorectal cancer will be the #1 cause of cancer-related death in people aged 20 to 49 by 2030. That's just 7 years from now. That is unbelievable. So now you know, obviously, why the ACS was so passionate about decreasing the age of onset of screening. A lot of these rates are really being increased by new diagnoses of rectal cancer. You can see from these graphs that we're expecting 100% or more increase in the diagnosis in our youngest individuals, 20 to 34, by the year 2030. We are not the only country documenting an increase in early onset colorectal cancer. All these numbers that you see here are countries documenting the same thing that we're documenting. So we always kind of assume that when we see these trends, particularly in younger individuals, that this has to be a United States specific phenomenon. It is not. This is an international worldwide problem. This is data that comes from the University of Colorectal Cancer, just showing that in our young patients, the longer it takes us to diagnose the disease, the higher the risk of finding the disease at stage 4. So part of this is kind of the public service announcement to really say we want young patients and all patients to be aware of this trend, but also to be checked out as quickly as possible. I also want to just point out that the research being conducted to find out why this is happening here at the University of Colorado Cancer Center, but it means, really just kind of focusing on people really from the development inside the womb all the way to adulthood with all of these kind of variables that go into this. So this is a very, very complex problem requiring a ton of research, a ton of researchers looking at investigations in every single stage of life to find out what's going on. So your third take-home point, the incidence of colorectal cancer overall in our country is decreasing, but increasing in our young patients, and research is ongoing to determine why this is happening. So how are we doing in Colorado? Dr. Wood gave you some of these numbers. What was the initial impact back in 2020 of COVID-19 on screening? And these numbers are a little bit unfair because obviously nothing happened in the healthcare system, right? In April, everything just basically stopped except for taking care of COVID-19. But there's a 90% drop in colonoscopies and biopsies in 2020 compared to 2019. That's 18,800 estimated missed or delayed diagnoses of colorectal cancer. What does that mean? We either missed the diagnosis altogether, or instead of catching a polyp, instead of catching at stage 1 or stage 2, now you're starting to catch cancers at stage 3 and stage 4. It's what we call stage migration. 1.7 million missed colonoscopies, which will lead to over 4,500 excess deaths from colorectal cancer over the next decade. The impact of COVID-19 was truly unbelievably remarkable in a bad way. How does Colorado do for colorectal cancer screening? Well, we ranked 31st out of 50 in 2018, and this was a 69% screening rate. And so this is kind of where we stood. You see some higher rates in the Northeast, and you see some kind of disparate results, particularly in the Southeast. But we kind of sat more or less in the middle. When you look at these same numbers, this was in 2018. When you look in 2020, there are 2 take-home messages. One, not only did Colorado's screening rate decrease to 63%, essentially every single state's screening rate decreased in the United States. The second take-home point is, interestingly, we didn't drop as much as other states, so that actually improved our ranking in 2020 compared to 2018. But you see this drop, and what does this mean? This means that we're missing diagnoses of colorectal cancer, or we're missing the opportunity to find it at an earlier stage. There are a couple of take-home messages from this graph right here, or this table right here, and that is only 36% of this really, concerning age group, right, where colorectal cancer incidence is increasing, only 36% are getting age-appropriate screening. And then Dr. Wood also talked about these disparities that we see in our Black and Hispanic populations. So take-home point number 4, Colorado rates of screening have decreased due to the recent, COVID pandemic. Screening is critically important, and we really need to focus on this younger population. They're not getting screened on time. Only 36% of 45 to 54-year-old adults are being screened, despite this alarming increase in early onset colorectal cancer. I'm going to just wrap up with these 2 slides. Obviously, why are we talking about this? Because the more we can get the word out about what is actually happening, not only in the United States, but across the world, the more we have a chance to save lives. And it's interesting that still, when you look at, where people kind of hear the message about screening, that the people are still going to trust their personal doctor the most. And so this actually came from the National Colorectal Cancer Roundtable, looking at the 4 essentials of improving screening. And that is to, number 1, make the recommendation, as reported, right, by ACS and the United States Preventive Services Task Force, develop a screening policy and make sure that you have a team that can implement that screening policy, to be persistent with reminders, reminding patients repeatedly, have you gotten your screening? Has it been done? Have you gotten your colonoscopy? And then measure to practice progress. And so these are kind of the 4 steps listed out by the National Colorectal Cancer Roundtable. And that's what I have for colorectal cancer. Thank you so much.
Thank you very much, Dr. Lieu, for your presentation, and particularly the portion relating to the growing incidence of colorectal cancer in younger adults. So I'd like to turn it over now to Dr. Wani.
Thank you so much. I want to start off by thanking the organizers, the ACS, for this invitation to speak to you this evening. I'm going to spend the next few minutes talking to you about the status of screening in Barrett's esophagus and esophageal adenocarcinoma, where we stand today, and more importantly, where we need to go in these next few years. I'm going to start off with a case, a patient that I actually did an endoscopy on about 3 weeks ago. And I'll just give you a brief history about this patient. A 52-year-old male with no significant medical comorbidities other than symptoms of chronic reflux disease for the past 15 years. He had mild obesity, history of smoking, and he was really plugged into our medical system. He saw his primary care physician on a regular basis. Unfortunately, by the time he saw me, he had started complaining of dysphagia, trouble swallowing. And when we did his endoscopy, we noted a large mass in the lower portion of his esophagus. We typically perform an endoscopic ultrasound to stage this esophageal cancer. The cancer at this point had already invaded all the layers of the esophagus into the surrounding structures. And we also identified a small lesion in the left lobe of his liver, making a diagnosis of stage 4 metastatic esophageal adenocarcinoma. Ladies and gentlemen, this is the status of screening. This is an example of how screening paradigms failed our patients with Barrett's and esophageal adenocarcinoma, and something that we should strive on a daily basis to change. I wish I could show you graphs that Dr. Lieu showed you earlier, where you saw declining incidence rates for colorectal cancer. This is the status for esophageal adenocarcinoma. And despite all the advances that we've made in the field of screening and surveillance for Barrett's and esophageal cancer, esophageal adenocarcinoma continues to rise. It is still one of the most rapidly rising incidence cancers in the United States. When you think about the 5-year survival rate for all comers, it's still a dismal less than 20%. So clearly efforts are to be made if we are going to have any impact on the epidemiology of this lethal cancer. The good news is, just like colon cancer has a pre-malignant condition such as colon polyps, esophageal adenocarcinoma does have a pre-malignant condition called Barrett's esophagus, where the lining of the esophagus changes due to chronic reflux disease. You see this pink or salmon-colored mucosa, and when you take biopsies that demonstrate intestinal metaplasia, that's how you make the diagnosis of Barrett's esophagus. Approximately 6% of US adults have this condition. Again, this is the pre-malignant condition for esophageal adenocarcinoma. I really don't want to ruin your appetite, but I just wanted to show you what endoscopic images of Barrett's esophagus looks like. This is the lower portion of the esophagus, and you can see a pink or a salmon-colored lining. That's an abnormal lining. And when you bring the endoscope back up, you can see that something's not right. You can see this nodular, bumpy appearing mucosa within the Barrett segment. And these are changes consistent with either early cancer or Barrett's associated high-grade dysplasia. This is an example of how we can make a difference. This is where screening actually was a success story, where we were able to detect early cancer, take care of this using our endoscopic tools, and avoid the morbidity and sometimes mortality associated with invasive surgeries or the need to undergo chemotherapy and radiation. So where do our guidelines stand in terms of screening for Barrett's and for esophageal adenocarcinoma? These are all the different guidelines that have been published, and you can see that it focuses on the risk factors of reflux disease with the presence of additional risk factors that include males age greater than 50, Caucasian race, central adiposity, smoking, or a first-degree relative with Barrett's or esophageal cancer. I'm going to talk to you about some of the limitations of using reflux disease to screen for Barrett's, and to circumvent some of these limitations. The most recent AGA guidelines actually suggested you should consider screening in the presence of 3 or more risk factors with or without the presence of reflux disease. I'm going to take a few seconds highlighting some of the limitations that we face as it relates to screening for Barrett's and esophageal cancer. Without a doubt, the burden that's placed on our medical resources is enormous. Our guidelines suggest you should be screening individuals with reflux, right? Can you imagine how many endoscopies we would need to do, considering the fact that 20% of the US adult population suffers from weekly reflux symptoms? Not only that, we know Barrett's esophagus can be completely asymptomatic. 20 to 50% of patients with esophageal adenocarcinoma have absolutely no symptoms of reflux disease. And the statistic that bothers me the most is the fact that less than 10% of all cancers that we see in clinical practice have a prior diagnosis of Barrett's esophagus, suggesting that our current clinical referral practices fail to identify the vast majority of high-risk individuals, even when you consider the fact that we perform more than 2 million upper endoscopies annually for patients with reflux disease. When you think about the burden of screening, this can range, depending on the guideline that you look at, it can range from 20 million to 120 million. Let's spend a few seconds understanding the barriers that we face as it relates to screening. This was a study we did where we really surveyed all primary care physicians. These are really the gatekeepers, right? These are physicians that see these patients who are at risk for Barrett's and esophageal cancer. only 18% of all primary care physicians ordered a screening test for Barrett's esophagus on a monthly basis. And I just showed you the enormous number of patients that we see on a daily basis who are at risk for Barrett's and esophageal cancer. Our primary care physicians also express some of these barriers listed on the slides: difficulty in identifying patients who are at risk for esophageal cancer, difficulty in following these published guidelines, and frankly, just not having enough time to even discuss screening for Barrett's and esophageal cancer. How well are we performing when it comes to actually doing an upper endoscopy for patients who are at risk? Unfortunately, not too well. Only 10 to 30% of all individuals in these large healthcare networks actually had an upper endoscopy. And I will tell you that these patients did not get an upper endoscopy purely for screening purposes. They got an upper endoscopy because they started complaining of difficulty swallowing, abdominal pain, or when their reflux symptoms were not adequately controlled. You've heard some data on how COVID has really impacted our screening strategies. So this was a study that we recently presented at our national conference, and this manuscript will soon be in press, where we looked at the impact of the pandemic on screening and surveillance for Barrett's and for esophageal cancer. It's not unexpected to see that during the first phase of the pandemic, we saw a significant decline in the number of patients, new patients, who were being diagnosed with Barrett's esophagus. We've seen a slight improvement, but we've still not caught up to the pre-pandemic days. What is most disturbing is the number of patients that got diagnosed with Barrett's-related dysplasia. Again, you can see a significant decline in the number of Barrett's associated low-grade dysplasia and high-grade dysplasia. If you focus all the way on the graphs to the right, you can see a slight improvement, but we've come nowhere close to the pre-pandemic cases. These are all patients who are in the community, have not yet been diagnosed with Barrett's esophagus or Barrett's-related dysplasia. Our conjoint analysis again showed similar trends where you see a precipitous drop in the number of patients with Barrett's and Barrett's-related dysplasia. And again, we've not seen an improvement. And we were actually able to analyze data all the way up to December of 2022 using these benchmarking registries. So where do we need to go next? Obviously, these are missed opportunities that we need to act on. We need to really focus on the subpopulations that are really at the highest risk for Barrett's and progression to esophageal cancer. We most certainly need to address for potential disparities in the way we prioritize scheduling this backlog of procedures. And of course, we need longitudinal data to see the impact of this pandemic on important patient outcomes, i.e. cancer stage and mortality. I want to spend the last few minutes talking to you about how we will be changing the way we screen for Barrett's and for esophageal cancer. This really potentially has the role to achieve this goal of population-based screening. Hopefully, I've convinced you that doing an endoscopy on everyone at risk is not tenable. So we need non-invasive modalities to screen for Barrett's esophagus. Imagine if you're at risk for Barrett's and esophageal cancer, you walk into my office and I have you swallow a capsule at the size of an antibiotic, a multivitamin. This capsule goes down into your stomach. It gets converted into one of these abrasive sponges or this balloon. I pull that capsule out, which is attached to a string. It collects cells that allow us to test for biomarkers. And based on those results, I tell you whether you're at risk for Barrett's, whether you need an endoscopy or not, or can I see you in 5 years where I can do this test again? How amazing would that paradigm be? I think we could screen almost everyone who was potentially at risk for Barrett's and for esophageal cancer. That's where we are. That's where we're going with all these different modalities. And I will tell you that the University of Colorado has been at the forefront of evaluating all these different technologies. Now, given all the research that we've done, our guidelines have now endorsed the use of these non-invasive tests to screen for Barrett's and for esophageal adenocarcinoma. I will tell you that almost everyone on our research team has swallowed one of these capsules. And I think the smiles on our face suggest that these are well tolerated. I think this can really be achieved in our clinic setting. One of the limitations, though, of course, is the fact that you need to come to see me, right? And see me in clinic or see your primary care physician. How amazing would it be if I could mail you a test where you could actually swallow a capsule that allows me to test for Barrett's esophagus? That's where we're going next. The enterotracker or the esophageal string test is what we will be evaluating. It's a small capsule. It's got a string that's really attached to this capsule, gives us a minimally invasive approach to screen for Barrett's. It collects cells just in the esophagus, and you can do it either in our office or you could do this at home. And this is a video of what this looks like. So this is the capsule. You pull the string out from this capsule, you swallow this capsule, and the string stays out. You attach it, it dwells in your esophagus for about an hour, and then you take the string out. And you can actually test for all the contemporary biomarkers that are associated with Barrett's and with esophageal cancer. We've already started enrolling patients in this pilot trial looking at this capsule test or the string test for screening for Barrett's and esophageal cancer. We talked a little bit about this, but I think this is also where we need to go. Imagine if you have a prompt every time you see a patient in clinic that tells you if your patient is at risk for Barrett's or esophageal cancer, which is a trigger for you to order a screening test. Hopefully, I've convinced you that non-endoscopic screening modalities really has the potential to improve our current screening paradigm. We need improved risk stratification and prediction tools that could be incorporated into our EHR. Future studies really need to address patient values and preferences, and without a doubt, we will not be able to achieve any of our goals without collaborating with our primary care physicians. We also need to collaborate with our colleagues at the National Institute of Health. We need their support. We need the funding to conduct high quality research. Here's an example of the ongoing SERVANT trial that's being funded by NIDDK using the U34 and U01 mechanism that will allow us to determine appropriate management for patients with Barrett's, a trial that's being conducted across 21 centers. This trial allowed us to bring the brightest minds in the field to really address some of the key questions related to esophageal cancer. Grateful to the NCI for funding this important biomarker trial to evaluate those patients with Barrett's who are at the highest risk for progression to esophageal cancer. We also need to collaborate with our industry sponsors, GI societies, to look at patient preferences for Barrett's and esophageal cancer screening tests. This is one example of how we can leverage this sort of support. We need to continue with our outreach programs, collaborate with these advocacy groups such as ECAN, ACS. And then finally, this is something that I feel very strongly about. We really need a population management culture shift where we need to ask this fundamental question: what can we do as a team to prevent esophageal cancer? Finally, I just wanted to share the recent announcement of our KDO and Paul M. Radioesophageal and Gastric Center of Excellence, which we just inaugurated a few months ago. Incredibly grateful to the Radies for their support. Thanks to Rich and Madeline Kane for their friendship and mentorship, and of course to my family. Thank you.
So thank you so much, Dr. Wani, for sharing your work, and here's looking forward to exciting times ahead with your work and the benefits that it will bring those in need. Thank you to all the presenters. We'd like to turn it over now for questions. Anyone has any? So is that on the microphone?
Hi, thanks for your presentations. They were really, is it on? Okay, really interesting. I just had a question. What role do you think that some of these multi-cancer early detection tests have in your respective cancers, and what some of the weaknesses are with those currently? Thanks.
Thank you for that question. I think multi-cancer early detection tests are really something that are very important. But I think we do need to make sure we understand what the clinical utility. So one of the large cooperative groups is collaborating with the NCI to collect cases and controls. And I'm the PI of that study. We'll have it open here. And then the NCI is doing a large study after that to really try and see how these tests perform and how we use them with the tools that we know. You've already heard about some great tools. We can't just throw those out. So I think that sometimes the horse is trying to get out of the barn, and we don't know who to test, how frequently to test. And we haven't really shown that you can diagnose cancers early. We need to do clinical trials.
I also wanted to open it up to people online. If anyone is online and has a question, you're welcome to put it in the chat and I can read it. Or if there's anyone else here.
Hi, thank you for the presentations. You all very well documented the decrease in screening during COVID. Is there any thought, planning, and I know not necessarily in your institutions, but that you're aware of for the next COVID, the next, which is coming? I mean, I think we all expect that sooner or later there's going to be another worldwide pandemic and we're going to shut down. Will there be a backup plan for the next one that says we're going to try to find a way to keep things going and not have this dramatic drop off because we're going to have all these excess deaths that we can attribute to the decrease in screenings?
Yeah, I'm happy to weigh in. I'm not sure that it's a phenomenal question. I'm not sure that there's a really great answer for it. You know, one of the things that we saw with this most recent pandemic was obviously things shut down for a bit, and then it felt like we just went into overdrive, and it kind of feels like we're still to a large extent doing that. We're just running scanners and endoscopies, and you know, the GI department's still backed up, right, from all of that. I think it really just depends, as it always is, on the nature of what's going on with the next pandemic and how virulent and how deadly it is. And there may be instances where a virus or a pathogen is just so deadly that it is going to shut everything down. And then we're going to run into the same problem because it's not like the medical system as a whole has a lot of reserve right now, right? And so it's hard to catch up. And I think that that's what you've seen over the last couple of years in all hospitals across the country and around the world. And then I think the other thing is lessons learned from this most recent pandemic. And so if, you know, a virus or a disease is not as deadly, maybe, right, then it certainly lends the ability to be able to do still some of these critical procedures and not shut everything down. as we've seen before?
Yeah, I think that's a fantastic question. And this pandemic really has provided a natural history or natural experiment in terms of certain diseases and conditions. And that's really sort of galvanized a lot of research in the field, specifically with regards to risk stratification and identifying those patients who are at the highest risk for progression. So there've been a lot of prediction tools that have been developed in these last few years to understand who are the patients that we should triage and prioritize. But at the same time, we've also learned who are the patients who could potentially wait for a few months if we were hit with another pandemic, and when should we schedule their endoscopy. So for example, a classic finding from some of the research done during the pandemic was that you could potentially wait for up to 8 to 9 months if you had a FIT positive patient undergoing a colonoscopy to schedule their colonoscopy. So that's the amount of time that we have. But you don't want to go beyond that time frame, because that's when you start seeing stage migration that Chris was talking about. So we've learned a great deal. And I think these last few years, there's been a lot of focus on some of these non-endoscopic or non-invasive modalities. The UK, for example, is already using those screening modalities that I showed you, using that sponge on a string or a balloon on a string to not just screen, but also do surveillance, because now we have biomarkers not only to detect Barrett's, but also to detect Barrett's with dysplasia or early cancer. So I see some of the benefits from the pandemic in terms of really pushing science forward with the biomarker research and risk stratification.
Thank you for your question. That's my dad. I didn't tell him to ask that. I think it's really interesting insights. All right. Now I would like to give a warm welcome to, let's give another round of applause for our people. Thank you so much. All right, I'd like to now turn it over to our sixth CD lead volunteer advocate, a dear friend who I've known for a long time here volunteering with ACS CAN. Sabrina Wright Hobart. Thank you, Sabrina.
Hi, everyone. Thank you to everyone, the great presentation. So I'm a 3-time breast cancer thriver. I use the word thriver because I'm living with metastatic breast cancer. Luckily, my status is no evidence of active disease. And for now, I truly am thriving. The drug that keeps me disease-free didn't exist in 2006, but researchers are constantly developing novel ways to treat cancer with more precision. There have been so many more treatment options developed in the 14 years between my diagnoses and my recurrence in 2020. With the advances in science, one of the ways that I'm monitored is through a simple blood test. Unfortunately, I'm an outlier. In 2023, in Colorado alone, it is estimated that 8,650 people will die from metastatic breast cancer. One of them is my good friend who just received the news that the breast cancer is now in her brain and all over her body. She is 44 years old and won't be here for her 45th birthday. That is why it's so important to keep advocating on behalf of those who can't anymore. With ACS CAN, individuals, patients, survivors, and their loved ones can advocate for real change and positively impact others affected by this devastating disease. I want to briefly mention some federal and state level work that ACS CAN has done and is continuing to do. At the federal level, ACS CAN has successfully advocated for increases in research funding for the National Cancer Institute, which is part of the National Institutes for Health. This money is important to support all kinds of cancer research that is imperative for finding new cancer treatments and an eventual cure. In addition, we are asking Congress members to co-sponsor the Medicare Multi-Cancer Early Detection Screening Coverage Act, a bipartisan bill that, as we all know, Senator Bennett is co-sponsoring and mentioned in his remarks. At the state level, ACS CAN and our Colorado action takers are advocating for passage of legislation that would require health insurance plans and Medicaid to cover the full range of biomarker tests necessary to link patients with the right cancer treatments at the right time for their condition, and to monitor the status of their cancer during survivorship. We cannot do this important work without your support. If you enjoyed today's event, please scan the QR code on this handout that you'll find on your table in front of you. All contributions to ACS CAN in support of our mission, no matter the amount, are appreciated and will help influence legislation and policy changes that will reduce the burden of cancer for all, and to help cancer patients like my friend celebrate more birthdays. This evening's event was one of some 40 policy events that ACS CAN held throughout the United States in 2023, covering a wide range of cancer control policy issues. This evening's presentation was recorded, and a link to access the recording will be sent to all of you, so you can watch it again or share it with your colleagues who weren't able to join us this evening. So thank you once again to our terrific sponsors and speakers involved in today's Policy Forum event. And thanks to all of you so much for joining us today. Please take care of yourselves and those that you love. And with that, I invite you all to continue to celebrate by joining us at the reception hosted by the University of Colorado Cancer Center that begins now at the back of the room. Thank you so much.